covers the pediatric chronic kidney disease. We also have a polling session for trainees and some cash rewards to make it exciting for them. And then instructions for the polling sessions will be given just prior to the session. And we will be providing CME credit hours as well. Just to let you know that Dr. Clivany is in the OR right now, but she's, she'll be joining as soon as she can. And unfortunately, Dr. Arvind Bagga could not join today because of an unexpected circumstance. But we do have a very eminent nephrologist with us today, Dr. Georgie Abraham. He is the panelist for today, and he will help us, going through the session. Professor Georgie Abraham is a senior consultant nephrologist at MGM Healthcare in Chennai, and he is also an adjunct professor at IIT Madras. Sir has been instrumental in advancing the field of nephrology and training next generation of nephrologists. He has been recipient of numerous awards and recognitions. He has received awards from American Kidney Foundation, International Society of Peritoneal Dialysis, International Society of Nephrology, Royal College of Physicians, and Indian Medical Association. He has more than 500 publications, including abstracts, book chapters. As you can see on the slide, his book, My Patients, My God, Journey of Kidney Doctor, is an inspiration for all the budding nephrologists. Again, thank you for joining us today, sir.
Thank you, Amrish, for that kind introduction. And thank you being part of this, to take pediatric nephrology ahead in South Asian countries.
Thank you, sir. Next, I want to introduce our first speaker for today, and who's an internationally recognized pediatric nephrologist, Dr. Franz Schaefer. Dr. Schaefer is a professor of pediatrics and chief of pediatric nephrology at Heidelberg University Hospital in Germany. He serves on boards and councils of numerous professional societies and is the current president of International Pediatric Nephrology Association. He is an eminent researcher and conducts numerous multi-center trials and established international research consortiums like ESCAPE, which we read quite a bit, International Pediatric Dialysis Network, and he also coordinates the European Rare Kidney Disease Reference Network, which is the ERK-NET, and the PODO-NET projects on nephrotic syndrome. Dr. Schaefer has more than 750 scholarly articles, book chapters with 48,000 citations and a H-index of 100. He is editor of several books, including Pediatric Kidney Disease and Pediatric Dialysis. We are honored that you could join us today, sir, and we are looking forward to your talk.
Thank you very much, and thank you for the invitation.
Yep. And then I will introduce the second speaker as well for continuity. And again, it is my honor and privilege to introduce Dr. Aditi Sinha, who is the professor of pediatrics and pediatric nephrology at All India Institute of Medical Sciences in New Delhi. Even my part of the training was at All India Institute of Medical Sciences, and it has always been a pleasure to reconnect. She is the past secretary of Indian Society of Pediatric Nephrology and represents internationally at International Peds Nephrology Association Council as well. She's recipient of numerous awards, including the ICMR Award for Research in Pediatrics. She has been instrumental in advancing research in pediatric nephrology at AIIMS and in India and worldwide. Her research interests include glomerular and tubular diseases, including HUS. She has had more than 300 publications, including multiple book chapters. Again, Dr. Sinha, we are delighted to have you here. Thank you so much for joining. And with this, I will stop sharing my slides, and I would request Dr. Schaefer for his presentation.
Can you see my slides?
Yes, we can, sir.
Okay, good. So thank you very much again for the kind introduction, and it's a pleasure for me to speak to you today about growth, longitudinal growth in children with chronic kidney disease and the endocrine abnormalities that lead to growth failure in chronic kidney disease. So when we look at the average height of children entering dialysis programs, this is what it looks like. You can see here the height standard deviation score. The normal range is between plus and minus 2. And more than half of the children at any age that enter end-stage kidney disease are growth retarded. They have a stunted height. Growth failure is not only a cosmetic problem, but it's actually associated with an increased risk of death on dialysis. And it is a major source of impaired quality of life in children with chronic and end-stage kidney disease, as we have found in a study that we performed a number of years ago, where it was very clear that patients' height satisfaction was correlated with the height SDS, so they really bothered with small height, and their quality of life was correlated with the height satisfaction. So what are the factors affecting growth in chronic kidney disease? Of course, there are always genetic factors. If you have small parents, you're more likely to be small. If you have a syndromic disease, you also have a higher likelihood of being small related to the underlying disease. But then the residual kidney function is a major determinant of growth rates, as you will see in a minute. And also, we know that isolated alterations of water and electrolyte balance can cause growth problems, hypokalemia, diabetes insipidus. These all can induce severe growth disturbances. And of course, water and electrolyte imbalance is a feature of chronic kidney disease, especially related to CKD in children. The same is true for metabolic acidosis, which per se can cause growth failure and is almost inevitably present in children with chronic kidney disease. But then there are also more specific problems related to chronic kidney disease, and one of them is uremic anorexia, which results in energy malnutrition. And I will focus a little bit in my talk on the problem of malnutrition and growth failure. And this is also related, as we now know, to a status of inflammation. So malnutrition comes along with inflammation. Inflammation causes anorexia. And inflammation can also cause hormonal disorders, endocrine disorders, especially regarding the function of the somatotropic axis, as we will hear more in this talk about. The different factors compromising growth act differentially according to the patient's age. And we know that nutrition is really most important in the first few years of life, and later on becomes a less important determinant of growth. And then there's the endocrine drive of longitudinal growth by the somatotropic hormone axis is becoming more important during mid-childhood. And then during adolescence, the sex hormones lead to the adolescent growth spurt, which can also be impaired in chronic kidney disease. So we have these three phases of growth where different problems predominate. So if we look at the prepubertal growth, this is a study we performed a few years ago where we compared children with hypodysplastic kidney disease. You can see here the 50th percentile as the dotted line, and then patients with an average GFR above and below 25. And you can see that at any age, patients with a lower GFR are smaller than patients with a better retained GFR. And so there is a correlation between the GFR and the growth rates. During puberty, we have the physiological pubertal growth spurt, which is more accentuated in boys, but also present in girls. And when we analyzed the large number of children or adolescents, I should say, that undergo pubertal growth, we found that the minimal height velocity before they're starting the growth spurt is very much depressed in chronic kidney disease. And then there is an acceleration, but the spurt reaches a lower peak height velocity, and it's also shorter lasting than the growth spurt of healthy children. This was true for both boys and girls. And it was also evident when we compared the growth rates to healthy children that are late maturers with a late puberty. Still, the growth spurt was much depressed. So in this phase, patients lose about 10, 15, 20 centimeters of growth potential irreversibly by a shortened and depressed growth spurt. So what is the relationship between nutrition and growth failure? Malnutrition is a hallmark of chronic kidney disease. In some countries, perhaps more than others, due to also socio-economic issues, and in the International Pediatric Dialysis Network registry, we found that countries like yours, like India, are at the lower end of the spectrum here. So the body mass index standard deviation score tends to be more depressed than in other countries. And at the other end of the spectrum, you have, for instance, the United States, North America, where obesity is a larger problem than malnutrition. But obesity is still a problem, and malnutrition is still a problem. And how does anorexia and the consecutive malnutrition come about? Well, we believe it has a lot to do with the accumulation of appetite modulators in uremia. So many of these factors that are listed here, which are satiety hormones, anorexogens, are accumulating in chronic kidney disease, especially in end-stage kidney disease, because these hormones are physiologically cleared through the kidneys. And if you have impaired kidney function, you have impaired metabolic clearance of these hormones. So they accumulate in the circulation and cause a feeling of continuous satiety. This is especially evident in patients on peritoneal dialysis. This is a study where the level of hunger has been measured throughout the day, and you can see that the physiological feeling of hunger is very much dampened in patients on peritoneal dialysis because they have the continuous presence of satiety hormones, and of course in PD also the presence of glucose that they are continuously resolving from the dialysate. So these are factors that dampen the physiological feeling of hunger in these patients. And it does matter though whether patients eat less carbohydrates, less energy, or less protein. And it seems that the energy intake is really the rate-limiting factor for longitudinal growth. In this very early study from the 70s, it was first shown that there's a direct linear relationship between energy intake and growth velocity. And only if patients, children were eating at least 70 to 80% of the normal energy intake, they were able to maintain normal growth rates. Conversely, if you eat less protein, and this is a study from our own unit in Heidelberg, where we performed 3-day dietary protocols of our children on dialysis, you can see that this is not correlated at all with the change in height standard deviation score with the annual growth rates. So patients eating less protein are actually safe, and this will not cause growth failure. It's really the energy deficit that causes the growth failure. And this problem is most pronounced, as I said before, in small infants, in the youngest patients, where growth is largely dependent on the ingestion of adequate energy. And you can help these patients who are not willing to eat more if you tell them so, but who will just start vomiting by enteral feeding. So you can use nasogastric tubes. Nowadays, we use more percutaneous gastrostomy tubes to force feed these patients. And as you can see in this case of a young girl, where we started tube feeding and dialysis on the 5th day of life, we were able to manage a normal weight gain and a normal length gain during her infancy period. And in the data of the IPDN, of the International Pediatric PD Network, we find that indeed patients who have enteral feeding, either through nasogastric tube or PEG feeding, they tend to be less at risk for malnutrition, but on the other hand, they tend to be overweight. Sometimes we feed them too much of energy and too much of protein, so they become obese from the enteral feeding. But at least if we don't overdo the job, we can prevent malnutrition. It's very important by providing enteral feeding, if available, in these patients. Now, moving on to the second phase, the prepubertal growth in the post-infantile period, we have to talk a little bit about endocrine mechanisms of growth failure. And I performed some research many years ago on experimentally uremic rats that underwent 5/6 nephrectomy to make them chronically uremic. And you can see that their weight gain could be increased by administering growth hormone. But this weight gain that we saw very markedly in control animals was attenuated in animals who were uremic. So there is a kind of growth hormone resistance, a relative growth hormone resistance in these animals. And we explored the mechanisms of this. We found that they were making less IGF-1 and IGF binding proteins as compared to their pair-fed control litter mates. And growth hormone is actually a hormone that signals through a very specific intracellular signaling pathway, which is the JAK-STAT5 pathway. So these are intracellular molecules that become phosphorylated when growth hormone binds to its receptor on the cell surface, and the phosphorylated form dimerizes and goes right into the nucleus, where it activates transcription of all the growth hormone target proteins. This phosphorylation is deficient in chronic kidney disease. And we see much less phosphorylation and hence much less activation of growth hormone-induced transcription in these animals. And why is that so? Well, there are endogenous regulators of the JAK-STAT signaling, which are the SOX proteins. And these suppressors of cytokine signaling are activated by cytokines, by inflammatory cytokines like the interleukin 1, 2, and 6. they very efficiently upregulate the SOX proteins, which then bind to the growth hormone receptor and block it from action. So, so this is the mechanistic link between the state of inflammation in uremia and the growth hormone resistance that we see in this condition. And indeed, when we looked at all the SOX proteins, we found them to be more expressed, overexpressed in animals with chronic kidney disease. So there's a molecular growth hormone resistance, a relative growth hormone resistance in uremia. On top of this, there's also accumulation of growth hormone and IGF binding proteins in the circulation, which inhibit the insulin-like growth factors from acting on their target tissues. So the accumulation of IGF binding proteins is another mechanism that causes IGF resistance. In addition, we found both in animal and human studies that growth hormone levels are normal, but the secretion from the pituitary is actually insufficient to overcome the endogenous growth hormone resistance in the state of chronic kidney disease. So animals and humans with chronic kidney disease cannot secrete more growth hormone as they should to overcome the state of resistance, and in this way have also a growth hormone insufficiency. What does that mean for the growth rates? Well, you can see here patients on dialysis, children on dialysis, they tend to lose height standard deviation scores. They tend to become relatively smaller than their peers over the years on dialysis, with the exception of the 0 to 1 year olds, the very young infants, where we can interfere with growth by the enteral feeding. There is one technology that we can use if it's available to improve growth on hemodialysis, which is hemodiafiltration. We performed a large study in Europe where we compared hemodialysis, conventional hemodialysis, with hemodiafiltration. And indeed, there was a slight stimulation of growth when we switched patients to hemodiafiltration. It is believed that some of the middle molecules that we can remove, and also some of the cytokines that we can remove better through hemodiafiltration than with standard hemodialysis, may be responsible for this effect. That is why in Europe we are now moving towards hemodiafiltration as the standard dialysis, extracorporeal dialysis modality of children. What about transplantation? Again, we see some kind of catch-up growth in the very young patients who tend to eat much better after transplantation. But we see surprisingly little change even after removal of uremia by transplantation in older patients after transplantation. And that is probably related to the steroid treatment that they receive for maintenance immunosuppression. In this study, where we tried steroid withdrawal in selected patients as compared to steroid-treated controls, we indeed observed quite a suppressive catch-up growth in the patients who were transplanted and then where the steroids were withdrawn. But the most effective therapy of growth failure in chronic kidney disease certainly is growth hormone therapy. We can now replace growth hormone or provide pharmacological doses of growth hormone several-fold more than a pituitary can produce. And this pharmacological stimulation of the somatotropic hormone axis indeed leads to catch-up growth as demonstrated unambiguously in this seminal study where growth hormone was compared with placebo for a time period of 2 years. If you look at extended growth hormone therapy in patients, in children with chronic kidney disease, you can see that the growth improvement endures. And after 6, 7, 8 years, in prepubertal patients at least, you can achieve complete normalization of height in most of these patients. And growth hormone is also active in infants, not only in older children. Initially, we thought it would not work in young infants, but here, this study in some 20 children aged less than 2 years clearly showed that there is a height benefit over placebo. It's very clear that it also works in very young children. The growth response to growth hormone is still dependent on the state of uremia, on the degree of GFR impairment. And dialysis patients tend to grow least well as compared to patients with some retained kidney function. So we are only partially able to overcome the growth hormone resistance. But what about the final height if you have pubertal patients that you are treating with growth hormone? This was a study we performed in Germany, and you can see an untreated control group. These were patients who were offered growth hormone treatment, but the families did not accept it. And these were patients who were put on growth hormone shortly before puberty started. You can see that there's a catch-up peak after the start of growth hormone treatment. And then there's a second peak of growth that is related to puberty. So these patients are enjoying a dual peak of their growth velocity, both boys and girls, that results in an impressive height gain, even in the pubertal period. And what does that mean for the patients? You can see these are the patients who were not treated with growth hormone. They were small, but many of them were still in the normal range at the first observation, and they lost growth potential during puberty. Whereas the patients who were very small but started on growth hormone therapy, they exceeded the growth of the untreated patients markedly, and they were entering at a final height around the 3rd percentile in the boys and well above the 3rd percentile in the girls. And if you look at the numbers, so the benefit was 10 centimeters in boys and 7 in girls, whereas the untreated patients lost 5 and 3 centimeters. And this relative benefit towards final height was also replicated in numerous studies later on in Europe and the United States. They all showed a benefit of growth hormone treatment even at pubertal age. And again, the duration of growth hormone therapy was a positive predictor of final height. The initial target height deficit was a predictor, and the percentage time on dialysis spent during the pubertal period was a negative predictor. So the longer the patients were on dialysis, the poorer the catch-up growth during puberty was. And you can see that here in patients on conservative treatment, they had the greatest benefit. On dialysis, they had the least benefit, and the transplanted patients were in between. So we later on analyzed whether all these measures, the supplemental feeding and the growth hormone therapy and so on, would result in better adult heights on the demographic level, on the population level. So we looked at all children in Europe in the ESPN registry and compared their final height outcomes over the years, starting in 1990 and then up to 2010. And you can see that the proportion of patients with very severe height deficiency, less than -3 height standard deviation scores, decreased, and also the ones with less than -2 decreased over time. But the actual benefit during these 20 years of observation was only half a standard deviation, or 3.5 centimeter height improvement over a 15 years period. We certainly will have to repeat this study now again, 15 years later, to see whether we further improve the final heights of our patients. I would be cautiously optimistic that this actually turned out to be the case. Again, there was, in the early days, the patients were losing height on dialysis, and now they are more or less maintaining a stable height, a stable growth rate when they are started on dialysis. But still, the years on dialysis are a negative predictor, and the most important predictor of the final height is the height at start of renal replacement therapy. So this means the taller you are when you start end-stage kidney disease, when you start renal replacement therapy, the taller you will turn out to be as a young adult. So it's very important to improve the growth in the pre-dialysis period and the pre-transplant period, when we do not have the suppressive effect of uremia and steroid therapy. Yes, and this shows again the height standard deviation score over time in the transplant population. And you see there was actually very little change over the years in this outcome. And this is a case that we treated basically from birth onward. And you can see that we managed to keep the patient growing within the percentiles for the first 1 or 2 years of life, and then he fell off the percentiles. We started percutaneous gastrostomy feeding, and we managed to improve his height gain quite nicely. And then we transplanted the patient, and you can see that without PEG feeding and without growth hormone, the patient fell off the percentile again. Unfortunately, this patient lost his transplant function, and part of the growth failure was certainly related to deteriorating kidney function. And he had another period of dialysis during which we applied growth hormone and made him grow back into the percentiles very nicely. And then he was transplanted again, and unfortunately this kidney, which was donated by his mother, did not work very well, and he was highly sensitized, so he had only a short time of transplantation. But during that time, he had so many problems that again he lost his height, his relative height, and he turned out to be less than 160 centimeters eventually. So we have good tools, but then there are sometimes problems that we are facing, in this case, after transplantation, that make the patients lose the gains that we were able to accomplish over some time. So it's very important to keep an eye on growth also during these transplant periods. We know that a growth hormone also works very well after transplantation and is safe. Yes, so this is failing growth due to failing grafts. And I think this was my last slide. Thank you very much for your attention.
Thank you, Franz, for that wonderful talk on pediatric growth and also endocrine issues. I just want to ask one question. You talked about everything. What about gonadal function in both males and females who are reaching puberty when they... please.
Yeah, I did not focus so much on gonadal function. We know that the patients go to puberty, so they have the awakening of the gonads and the emergence of sexual production. It starts late, probably due to this chronic state of sickness, of illness. They have a late puberty, but when it comes, it usually progresses quite normally. One problem that boys have is azoospermia. They have a suppressed sperm production. But girls are indeed fertile, and we actually have to advise the adolescent girls about contraception and so on. So even on dialysis, they seem to start cycling, and they are indeed fertile.
Do they have any anovulatory cycles, or they are normal cycles? Anovulatory cycles or normal cycles?
Yeah, they do have anovulatory cycles as well. And of course, the hemodialysis girls, they have menorrhagia quite often because they are anticoagulated. So that can also be a major problem. But eventually, they develop ovulatory cycles.
Thank you so much. Any questions in the chat box? Any questions from the floor?
Yeah, there was one question in the chat box, and I think Dr. Schaefer already answered that. It was related to resistance of growth hormone in patients of ESRD, and at what time, we can give growth hormone, and please share your experience. I think you went into pretty much detail. The question came, before you had started discussing it. So we can skip that one, but there is another question in the question and answer box, and here it's more related to transplant period. So in a year post-transplantation, a patient has high PTH, normal calcium, normal vitamin D, and normal phosphorus. When can we start growth hormone? So in a transplant patient, when would you recommend starting a growth hormone?
Yeah. So we usually start growth hormone 1 year after transplantation, because we first watch the spontaneous growth rates in the patients to see whether they have spontaneous catch-up or not. If there's inadequate growth during the first year, then we start growth hormone, and we would not be shied away by a high PTH. Unless it's excessively high. But normally these patients, their bones tolerate the growth hormone therapy quite well.
There's one more question, and it is when to stop the growth hormone therapy.
Yeah. So in patients with CKD and on dialysis, we basically never stop growth hormone therapy until final height is reached. So of course we do the bone age and so on, and when there's very little growth potential left, then we take a decision to end the growth hormone therapy. So we would, because we know that if you stop growth hormone therapy, there can be relatively quick catch-down growth. So patients can stop growing and lose the gained height in a few years. So we always continue the treatment until final height. What may be the cause of not catching growth after transplant? Yeah, I think it's mostly the steroid problem. So if you can manage to keep the patients with very low doses or off steroids completely, then you usually see catch-up growth. And then the other point is deteriorating kidney function. Many of our transplant patients are actually CKD patients. And we tend to forget about that. We tend to forget about the CKD sequelae in patients after transplantation. This could be a webinar in itself. And then, growth failure is just a secondary consequence of the re-emerging kidney failure.
Yeah, thank you. The next question is, do we need to screen for thyroid hormone levels regularly in a chronically diseased child?
We do screen thyroid hormone levels, but I'm not sure why, because you have this specific constellation of chronic disease patients. You have the low T3 syndrome, so the sick euthyroid syndrome, as it's also called, that you usually see, but you almost never see overt hypothyroidism.
Yeah, thank you. Dr. Abraham, do you want to add?
No, I think that it was an excellent disposition and it was lucid. I'm so happy that our pediatricians will benefit. The only question here is, are we using, I'm asking the pediatric nephrologist, especially Aditi, are we regularly using recombinant growth hormone in our patients? Or we show some hesitation in using that? Aditi is there, whether she can answer
Yes.
that. Aditi?
Hi.
Yes.
Hi, good afternoon, good evening. So, in our experience, it's been a bit, we have used growth hormone, but not regularly. It certainly isn't as regularly as one would want to. It is when the window is there from between transplantation up to transplantation, then definitely that there's scope to do that. Very often, our chief concerns are around diet per se. Unless we build up the nutrition to a certain level, we don't achieve growth. And beyond that, if required, I mean, we have occasionally, I mean, we do use growth hormone, but certainly it's not half as frequently as one would like to. It's
I just
usually
have a
cost and
question
other
to
considerations. Yes.
Yeah, Frank, I have a question to you. I have a young kid, he's 14 years old on APD with a dense deposit disease. And on APD, he doesn't eat well, but his appetite is better when we do CAPD for him. So you have any comments for that? Franz?
It is better on CAPD than on APD?
Yes, he's on APD regularly, using nearly 10 liters, but his blood pressure is not well controlled on APD. There is no day dwell. So I told the parents to put him on CAPD, and his creatinine and urea has come down, and his appetite has improved with some appetite stimulating agents, such as we call it as one of their products. So I'm just wondering, you think that APD is better or CAPD is better in terms of growth and also in terms of improvement in appetite?
In terms of growth, there's no difference. We have looked at that. So, when you do the APD for 10, 11 hours, it's the same growth rate. You can expect the same growth rate as with CAPD. For the appetite, some of our patients with CAPD complained of loss of appetite from the CAPD because of the continuous glucose resorption during daytime. But there are probably individual differences. It's a little bit difficult to predict.
Thank you. Thank you for that comment.
Yeah,
I think we should move over to the yes, Amrish, please move on.
Yeah, so we can just do the last question and then we can move on to Dr. Sinha. It's a complicated case. Looks like a child who has developed post-transplant diabetes mellitus and is on growth hormone also. So would you discontinue growth hormone, or we can continue good glycemic control with growth hormone?
I think if you have good control, you can keep the patient also on growth hormone. I mean, when the patient is insulin dependent anyway, I think it will not change the course very much. So I would keep the patient on growth hormone and insulin.
Yeah. Thank you so much, Dr. Schaefer. Yeah. This was an excellent discussion by the panelists. Thank you, Dr. Schaefer, for joining us. And we will move on to Dr. Sinha and looking forward to her talk.
I'm sorry, I was muted. Are my slides visible? Yeah.
Can you make it slideshow, please?
I did already. Is it not yet
No,
in
it's,
slideshow?
no, it's not in slides. Now
Now
it's
it
on.
is.
Yes.
Okay, I think there's a bit of a lag here. If it goes off slideshow, do let me know, please. Thank you. So my topic would be that was assigned to me was to discuss about progression of chronic kidney disease in childhood, which would be kind of incomplete without discussing really the strategies to retard this progression. And I thought my job for the day would be between these two aspects. So we understand, we've heard about chronic kidney disease in last week's webinars as well, when Dr. Sriram covered in detail how the pathophysiology and progression of chronic kidney disease happens. And he did dwell on this aspect of how once chronic kidney disease has been initiated, there are ways in which glomerular disease and tubular interstitial injury is perpetuated through processes which involve inflammation, glomerular loss, tubular interstitial damage, injury, including through various mechanisms, including inflammatory pathways and ischemic and hypoxia-mediated injury, which further leads to perpetuation of a cycle of maladaptive repair, which goes on to lead to progression of chronic kidney disease. So once nephron loss has begun, it is inevitable regardless of the etiology. Of course, where there are ways to handle the etiology, etiological evaluation has a role in providing us clues to the once diagnosis is established and specific management can be done. That is definitely required. But once we have chronic kidney disease, which has set in with a low EGFR being present, through maladaptive repair and through hyperfiltration injury at the glomerulus, there are activation of the renin-angiotensin-aldosterone pathway, leading to increased proteinuria, intraglomerular hypertension, which further perpetuates inflammation, causing remodeling, and tubular interstitial fibrosis and secondary focal segmental glomerular sclerosis, which further leads to lowering of GFR, increased proteinuria, and further perpetuating inflammation. So these pathways are activated in majority of patients with chronic kidney disease to one or the other extent, with higher extents being present in patients who are more proteinuric and with lower GFR. So I hope that my, just a moment, sorry. Are my slides?
No, you have to put on slideshow.
So,
it's not on slideshow.
So, sorry. So we have these risk categories based on estimated GFR and albuminuria that have been established for adulthood onset chronic kidney disease, wherein a heat map has been devised based on the relative risks or hazards ratios of disease progression or adverse outcomes, including cardiovascular outcomes as well as kidney outcomes, through which we have established a kind of a traffic signal based kind of risk categories, which are progressively worse for degrees of proteinuria and lower GFR categories. So in populations with chronic kidney disease, both GFR and albuminuria are important to quantify at baseline because they indicate the risk of progression of chronic kidney disease as well as the risks of various kidney and non-kidney outcomes. Now, the rates of renal function decline are also very important. The rate of GFR decline in most patients with adulthood onset chronic kidney disease are fairly at about 1 to 4 ml per minute per 1.73 meter square per year annually. Patients with faster GFR decline are known to have higher morbidity, and patients who are declining faster than 5 mils per minute per 1.73 meter square annually are considered to be rapid progressors, and they are the targets of various intervention strategies. And you can see that these trajectories over a period of time could vary, but overall we know that at higher GFRs, the rates of progression tend to be slower, and as the GFR declines to a low value, the rate of progression tends to become more rapid. Now, various studies have established different rates of GFR decline in adult kidney diseases, but we do know that these rates vary by certain factors. Now, the main factors that determine the rates of progression broadly would be an etiology and the degree of proteinuria. Now, the etiology is pretty important because we know that for various even glomerular causes, the rates of progression really vary. So patients with primary focal segmental glomerular sclerosis, which do not turn around, the proteinuria does not turn around with whatever intervention that you're carrying out, would tend to progress the fastest. The rates of decline in IgA nephropathy and membranous nephropathy would be slower. Patients who have diabetes would have no decline in GFR till a certain while, till diabetic nephropathy sets in, and subsequently the decline depends on the degree of proteinuria or albuminuria. And patients with non-glomerular etiologies such as autosomal dominant polycystic kidney diseases tend to decline the slowest, achieving end-stage kidney failure in later decades of life. Now, overall, the sense is that glomerular diseases tend to fare worse and definitely progress faster than non-glomerular diseases, even in childhood. And we know that in childhood, congenital anomalies of kidneys and urinary tract tend to show slower declines in GFR than do patients with glomerular etiology. So you might diagnose an FSGS at an older age than a patient with a CACUD, but the time to achieving a kidney failure would probably be faster in the patient with FSGS. Overall, patients with hypodysplastic kidneys tend to have low GFRs beginning from early childhood, but they tend to not progress right up to adolescence, when around puberty, there is a rapid change or decline in GFR, and suddenly a faster decline is observed. So ongoing studies, cohort studies, continue to examine these trajectories in childhood. Now, what are the risk factors for progression? Now, many of the risk factors of progression can be categorized into chronic kidney disease related factors, environmental factors, general metabolic factors, and certain non-modifiable risk factors. Now, the most important factors are at the top here. So proteinuria and hypertension, which are both linked to RAS activation, are the most important determinants of progression of chronic kidney disease, be it in adult CKD or in pediatric CKD. Other factors also contribute, including dyslipidemia, metabolic acidosis, hyperuricemia, altered calcium phosphate metabolism, anemia, and inflammatory pathways activation. Certain non-metabolic factors, non-modifiable factors are always at play, such as the sex. Men in various diseases tend to progress faster than women. Certain genetic predispositions might be there, and we'll dwell on that briefly. The age at onset, the younger you are at onset, probably the more likely kidney failure is likely to happen. And certain issues around fetal programming, such as low nephron endowment, would be important. Obviously, metabolic risk factors such as obesity, exogenous intake of extra salt, presence of diabetes, type 2 diabetes, would also contribute to risk progression. Now, some of these do not apply as much to pediatric CKD as they do to adult CKD, but many of them stay relevant even in childhood. So hypertension and proteinuria have interrelated mechanisms by which they determine intraglomerular hypertension. They contribute to each other, as well as both of them signal various inflammatory pathways. Both vasoactive signaling is activated as well as pro-inflammatory signaling, which leads to through various mechanisms, tubulointerstitial inflammation, and further glomerular hypertrophy, intraglomerular hypertension contributes to glomerular hypertrophy, which further leads to glomerulosclerosis, which further declines the nephron mass. So all these pathways, there are various targets, as you can make out. Obviously, antihypertensive agents would control hypertension. RAS antagonism has been an important favored strategy to reduce hypertension and proteinuria, because it acts not just at the glomerular level, but also at other levels, including inhibiting signaling of various cytokine pathways, as well as vasoactive signaling, which lead to improvements in outcomes. Now, I mentioned genetic polymorphisms influencing the risk of disease progression, and various studies have demonstrated that certain polymorphisms in the ACE, certain single nucleotide polymorphisms in certain genes, and certain copy number variations in genes which are known to be implicated in, say, monogenic CACUD, such as HNF1 beta, might have might have disease progression implications, as shown in various studies. Overall, proteinuria and hypertension remain the most important determinants of the renal function trajectory, which are also influenced by each other, as well as contributed to by the glomerular etiology or non-glomerular etiology, the gender, and the presence or absence of other factors such as diabetes or inflammation ongoing. Now, certain biomarkers have been examined for their relationship with prediction of GFR decline, and some of these are listed on this slide. However, at the moment, none of them are clinically relevant enough to be used for practice. As you can see, albuminuria remains the most important determinant of the renal function trajectory, and with intervention, if this can be declined, maybe the trajectory could be changed. So Proteinuria is both a marker as well as a mechanism for progressive kidney disease, both in adults and in childhood populations. 2 large studies in the past carried out in adult CKD demonstrated that GFR decline was associated with proteinuria. For every gram increase in proteinuria, the GFR decline was higher by 1 or 2 ml per minute per year in the MDRD and the RAIN studies. And this was borne out by other registry data as well. How about childhood CKD? There are cohort studies from Europe, including studies from the conducted by Dr. Schaefer's group. There are studies from Italian registry, the Japanese data. All data sets seem to indicate that the presence or absence of proteinuria is an important determinant of the time to kidney failure in even pediatric patient groups. And therefore, based on the data from 2 large data sets of pediatric CKD, the CKD cohort and the ESCAPE cohorts, authors, including Professor Schaefer, were able to determine heat maps for indicating the risk of progression of pediatric CKD as well. Now, this data set was huge, based on more than 1,000 children in the 2 cohorts for GFRs between, say, 30 to 90, and they could create heat maps which were different for non-glomerular etiology of proteinuria versus the glomerular etiology of proteinuria. And as you can look at the slopes of these trajectories, you can see that patients with glomerular etiology tend to progress faster. And you can also make out that these risk groups A, B, C, D, E, F differ in terms of their baseline GFR as well as the albuminuria categories. Now, these risk groups can be used to sort of provide guidance to families when they come to us with a certain stage of chronic kidney disease, and we can determine their GFR at that point of time and the proteinuria at that time point. And we can use that to tell them that the expected time to kidney failure event is such and such. For example, a patient in the green trajectory, if he's glomerular in etiology, might progress 50% of the time more than 10 years later. On the other hand, someone in the F category in the glomerular disease is likely to progress as rapidly as 0.8 years, 50% of the times. So what is the advice about monitoring GFR and albuminuria? Now, albuminuria is what entire adult CKD population would be measured in terms of, whereas the pediatric population still stays in terms of urine protein creatinine ratio. We haven't gotten to equivalences of albumin creatinine ratio and protein creatinine ratio. Nephrotic range proteinuria, that is UPCR more than 2, would be the same as about A3 category. And looking at that, we would think that these are not just heat maps, but also times to screen, times to treat, and definitely must treat albuminuria in these zones. So assessment of albuminuria or proteinuria in childhood should happen at least annually. And for those at higher risk of CKD progression, the frequency of screening and treatment should increase. And definitely in presence of moderate to severe proteinuria, treatment is definitely warranted, particularly so at low GFRs, patients with even mildly increased proteinuria should be treated. Now, there are various risk prediction models of adulthood CKD. We are aware of the KFRE, which is quite commonly used by adult physicians to understand the risk prediction to kidney failure outcome. They have decent prediction for kidney failure, but they do not have great prediction for all-cause mortality and do not predict cardiovascular mortality very well. On the other hand, in pediatric CKD, we are still to get to that place where we have great models of progression of pediatric CKD, but certainly using components such as the glomerular disease etiology, baseline GFR, and proteinuria grade, different groups have arrived at rates of progression to CKD5 differently, but you can make out that certainly glomerular etiology and heavy proteinuria groups tended to progress faster or more often to chronic kidney disease stage 5. Overall, it is clear from data from childhood cohorts as well that proteinuria and hypertension remain predictors of loss of GFR in children with CKD as well. And this is well demonstrated from the low protein diet study as well as the Japanese ESCAPE and CKD cohorts, that proteinuria and low GFR at baseline predict progression of kidney disease. There are certain things that we can take inherently from adult cohorts and find similarities in childhood. For example, the CKD cohort study has also demonstrated that it's not just the 1-point assessment of blood pressure that predicts CKD progression, but also progressively looking at later follow-up time points, and patients who tended to have blood pressures in the high range continuously tended to progress more often than patients who had consistently controlled blood pressure. So overall, this brings us to the topic of how can one retard progression of chronic kidney disease in children. And this kind of cartoon sums up the various strategies that one would think around to retard kidney disease progression. As we said, hypertension and proteinuria, the two points in bold, are the chief targets of all our interventions. And the majority of my talk would dwell around this aspect of how to handle hypertension and how to handle proteinuria through various mechanistic pathways being inhibited to reduce hyperfiltration injury, intraglomerular hypertension, glomerular hypertrophy, nephron loss, and decreased signaling of pro-inflammatory pathways. So first and foremost comes blood pressure control. Now, there is enough data and more data to demonstrate that blood pressure control is clearly linked with retarding progression of adulthood onset chronic kidney disease. There have been major trials on intensive control versus standard blood pressure control, and they have clearly demonstrated that adequate control of blood pressure is associated with slower EGFR decline. The tighter your control, the better the difference in EGFR decline. Now, many of these trials have looked at ACE inhibitors and ARBs predominantly, and the RAIN trial, the renal, the ASK, the IDNT, and Nephron D have all demonstrated that patients who receive good control of blood pressure would show slower EGFR decline. And there has been impact also on non-kidney outcomes, including cardiovascular outcomes, and updated analyses indicate that not just kidney outcomes, but also non-kidney outcomes would be lower in patients who have intensive blood pressure control versus those that have just about adequate or not so great control of blood pressure with medications. Dr. Schaefer is responsible for the conduct of this study, the ESCAPE trial, and which clearly demonstrated that strict blood pressure control was associated with slower decline in kidney function in childhood chronic kidney disease as well. Now, this seminal trial enrolled children 3 to 18 years with GFR between 15 to 80 mils at baseline, and they were subjected to either intensified blood pressure control targeting 24-hour ambulatory blood pressures below 50th centile versus conventional blood pressure control, wherein the targets were gentler between 50th and 95th centile. And the time to GFR decline by 50% or end-stage kidney failure was clearly lower, clearly slower in patients with intensified control than conventional control. The risk of progression was lower with intensified control. However, there was a phenomenon of reappearance of proteinuria following a period of tight control, which was associated with long-term ACE inhibition. The predominant medication used in this study was ramipril, with add-on other antihypertensives being permitted. So overall, this slide kind of summarizes what are the various strategies that have been used or are currently being examined to retard progression of chronic kidney disease. Now, many of these strategies center around RAS inhibition, and these include ACE inhibitors, angiotensin receptor blockers, direct renin antagonists such as aliskiren, and then there are this group of mineralocorticoid receptor antagonists, which are divided into two broad categories, the steroidal ones and the non-steroidal ones. And for various reasons, through studies, it has been arrived at that the non-steroidal mineralocorticoid receptor antagonists seem to be superior in terms of providing more selective antagonism of the mineralocorticoid receptor in the kidneys with lower rates of hyperkalemia than the steroidal ones such as eplerenone. Then there is a novel group or novel target, that is the endothelin receptor. The type A inhibitor of the endothelin receptor, atrasentan, has been examined as a antifibrotic strategy in patients with IgA nephropathy. Then there are the dual endothelin antagonists, that is the dual antagonists, that is the endothelin receptor antagonist as well as the angiotensin receptor antagonist, called as DERA as a short form, of which the classic example is sparsentan, which has been examined in certain conditions, including in pediatric kidney diseases. And then we have other drugs which are less used in kidney diseases and more often in heart failure patients, including the neprilysin inhibitors. And increasingly, we have evidence to support the use of sodium glucose-like transport inhibitors. Now, these are the mechanisms that are listed, but overall, what has been tested in pediatric population and is approved for use in pediatric population has been the conventional RAS inhibitors like ACE inhibitors and ARBs, and also aliskiren, the direct renin antagonist. The others are not yet kind of licensed properly for use in childhood CKD, but are beginning to be examined in various trials, as I'll go through now. So RAS inhibitor has been the mainstay of therapy for retarding disease progression in both pediatric as well as adult chronic kidney disease. There is ample evidence now to recommend their use in early stages of chronic kidney disease to retard progression across disease categories, and the various mechanisms by which they alter gene expression, reduce oxidative stress, reduce inflammation, apart from reducing glomerular hyperfiltration injury, are shown in this cartoon. And overall, if we look at the role of renin-angiotensin system blockade in chronic kidney disease, including not just diabetic patients, but also non-diabetic patients, there is ample evidence from meta-analysis now in adult CKD that indicates clearly ACE inhibitors are the leaders, followed by ARBs, in reducing the risk of kidney failure, all-cause mortality, as well as cardiovascular death. In diabetic CKD, there is more substantive evidence, definitely, of reduction of proteinuria and mortality as well. Overall, ACE inhibitors seem to have a slight edge over the ARBs in this context. Other antihypertensive agents seem to be effective in retarding, in improving hypertension control, definitely, but the occurrence of kidney failure odds are probably a shade higher, although not significantly very different. CCBs may probably not be as renoprotective, although the evidence is not very clear in this regard. Now, what about studies such as in children? Now, we had this, there was the study of ramipril versus placebo in patients with Alport syndrome, which is a multicentric study, which specifically looked at the role of early use of ramipril, which did not show major benefit through the early protect study. But then there is more data emerging from retrospective cohorts that shows that definitely adding on ramipril early on in the disease trajectory might help retard progression of disease in patients with Alport syndrome. And this continues to be examined in randomized controlled trials. What about, reducing residual proteinuria by adding on an ARB to ACE inhibitors in patients who continue to be proteinuric or hypertensive despite use of an ACE inhibitor? Now, dual blockade of RAS had been carried on for several years until many studies put together in meta-analyses indicated that while there was modest benefit in proteinuria reduction by almost 20%, there was not great benefit in terms of reducing the rates of GFR decline. Definitely mortality was unchanged, and certainly there was an increased risk of adverse effects, including significantly increased risk of hyperkalemia and sudden decline in kidney function, which led to adverse events such as hypotension and led to patient withdrawal from studies. So overall, the benefit of dual blockades do not outweigh the risks, and therefore, given the high risks, they are not a preferred way of managing patients, and dual blockade would not be a standard of care anymore, and single RAS inhibition would be preferred. However, studies are continuing to examine add-on role for non-steroidal mineralocorticoid antagonists such as finerenone and dual blockade, as we shall be coming to just now. So overall, what is the KDIGO advice on use of RAS inhibitors? They recommend starting RAS inhibitors in patients who have severely increased albuminuria, even without diabetes. And with moderately increased albuminuria, the evidence being less certain, they only give a suggest recommendation, that is a 2C recommendation. Patients who have albuminuria and diabetes, they would recommend certainly starting, and they recommend against combinations of ACE and ARBs and DRIs in patients with CKD. They also further go on to advise that therapy should not be initiated at GFRs below 20. Now, what is the context of below 20? Obviously, there is a pro and con to using RAS inhibition in advanced CKD. Patients are at higher risk of complications, and there were factors favoring or not favoring. And studies that previously examined in cohort studies, prospective and retrospective from Sweden and Japan, they demonstrated that they had controversial evidence. One study showed that there was decline in function with continued use in advanced CKD. The other study showed that there was benefit in preventing need for dialysis. Now, the STOP ACI trial was conducted as a multi-center study to examine exactly this aspect: what happens if we continue using ACE inhibitors below 30 GFR or not. And overall, the study failed to find any differences in rates of GFR decline or the rates of requirement of renal replacement therapy. And therefore, the study did not provide a clear answer as to whether it should be continued or discontinued. Given the rates of adverse events associated with ACE inhibitors, many people would be cautious. Most experts would be cautious using at low GFRs. In childhood, there was one study which has looked at the rate of eGFR decline. It surprisingly it found that early on there was no difference in slope if you were to continue or discontinue, but later on the eGFR slope declined rapidly, and therefore one would be wary continuing to use RAS inhibitions at low GFRs below 25. So the advice from KDIGO is that you can start ACE inhibitors early on, but you would probably not continue if there is a rapid decline in GFR by more than 30% within 4 weeks, and consider reducing the dose at such state, or if there is symptomatic hypotension or hyperkalemia. And if the GFR falls below 30, if you can safely monitor these patients, then you may continue. What about children? KDIGO 2012 had recommended ACE inhibitors and ARBs for anti-hypertensive control, and this continues to be the preferred agent in the AAP recommendations 2017, the KDIGO recommendations of 2024. Overall, our do's and don'ts: you need to monitor creatinine and potassium and bicarbonate at initiation within 2 to 4 weeks and at every visit. The therapy should be titrated to achieve optimal control of blood pressure as well as proteinuria to a maximally tolerated level. We do not advise using combinations, and certainly patients should be advised against using RAS inhibitors on sick days, so you would have to provide clear advice in this regard. You have to watch out for acute kidney injury, particularly in a situation where hypotension is likely or combinations or other drugs are being used, which can lead to problems such as NSAIDs or other RAS inhibitors, and these patients would require close monitoring for creatinine and kidney function and potassium. Dietary considerations: we would advise them to not have too many juices, etc. Avoid ultra processed foods because they would be high in potassium as well, and the constipation should be treated adequately. One should look out for hyperkalemia at every visit, and certainly at potassiums above 5 we would not want to start therapy. So the KDIGO provides a good cartoon to how to monitor these patients on creatinine and potassium aspects, and listeners are advised to go over this chapter in the KDIGO 2024 guidelines. Switching gears to another strategy that has been recently examined, that is the mineralocorticoid receptor antagonism, of which the classic example of most use is finerenone, and this is an example of a non-steroidal MRA, and it is potent and selective, and it's at equipotent doses of eplerenone. It has been shown to have better blood pressure decline and better inflammation control in animal studies. So this is how the journey of NSMRAs has evolved from cardiovascular disease into kidney disease, and now there is enough data from trials in adult chronic kidney disease patients that use of finerenone versus placebo is associated with a higher decline in albumin-creatinine ratio and a lower decline in eGFR from baseline. And therefore, these advantages being there, finerenone has come to stay in the adult chronic kidney disease world as an add-on to patients with already on ACE inhibitors, but therapy requires close monitoring for potassium and creatinine. And this is the KDIGO advice for adult patients, that patients who with type 2 diabetes in particular, with sufficient GFR, normal potassium and albuminuria, they could be added, or therapy could be added on. However, it is more appropriate for patients with diabetes than for non-diabetes, and that is still to be settled. Another therapy way that has been examined is endothelin antagonism, chiefly the type 1 receptor blockade, because it is associated with vasoconstrictive injury and inflammatory pathways activation, and dual endothelin and angiotensin receptor blockade with sparsentan has been examined in 2 studies in FSGS as well as in IgA nephropathy, and continues to be examined in other studies at the moment. The most important studies that I would like to just highlight here are the DUET and the DUPLE trials, in which patients with FSGS experienced better albuminuria control when given sparsentan than when irbesartan was used. And there is some suggestion that kidney function was better preserved through the DUPLE trial, that there was better preservation of kidney function in the sparsentan group than in the irbesartan group. The other pathway that has been examined is SGLT2 inhibitors. Now, SGLT2 inhibitors are the new kid on the block and really turning things around for patients with chronic kidney disease in adult patients. It started out as a mechanism for achieving better glycemic control in diabetic nephropathy, but the patients were shown to have better natriuresis and better blood pressure control, and therefore it began to be examined in patients with for the kidney outcomes as well. And so in advanced diabetic kidney disease, certainly meta-analysis demonstrated that not just was the diabetes control better as an add-on with SGLT2 inhibitors, but also the major adverse cardiovascular events as well as kidney outcomes were better with SGLT2 inhibitors than other therapies such as GLP-1 analogs. However, the benefits being less clear in non-diabetic kidney disease, now it has begun to be examined in other kidney diseases. So these are three major trials, the Credence, the DAPA-CKD and EMPA-CKD, of which outcomes in the kidney context have been looked at in patients both with diabetic kidney disease as well as non-diabetic kidney disease. And clearly there has been benefit in terms of better eGFR preservation, in terms of GFR slope, as well as albuminuria control. There have been benefit with use of SGLT2 inhibitors, such that certainly meta-analysis indicate that across various GFR categories by the KDIGO and across the albuminuria categories of the KDIGO, the benefit from use of SGLT2 inhibitors is clearly evident. Showing that GFR decline might be slowed by 10 to 15 years if you were to add on dapagliflozin. Now, this is the recommendation that's recommended for patients with diabetic CKD, but also recommended with other CKDs as long as they have preserved GFR and albuminuria. And right down to 20 GFR, these can be continued to be used. This has been examined in the context of the IgA nephropathy. Subgroup analysis also has demonstrated benefit specifically in IgA nephropathy. And in IgA nephropathy, just for sake of completion, I just wanted to bring in sparsentan, which was the dual antagonism of angiotensin and endothelin, wherein benefit was demonstrated for IgA nephropathy specifically. What about childhood? The SGLT2 inhibitors, there is very limited data from childhood studies. This requires definite examination. These are just prospective single limb studies or retrospective data that demonstrate probably not so great benefits so far, because proteinuria decline has not been consistently demonstrated in these studies, nor has, and there are some signals of changes in GFR which are not in the good direction. So it requires clear examination through trials which are ongoing, and certainly this is the need of the hour for us. Another thing that's on the annual for diabetic CKD has been GLP-1 agonists, and definitely looking at residual risk, residual proteinuria, this has begun to be examined. Kidney outcomes are also being examined with GLP-1, and we see trends in the FLOW study that semaglutide was clearly beneficial in type 2 diabetes, and maybe there's more studies to come which will indicate benefit in other groups as well. I'll just switch tracks quickly and go over 3-4 concepts which are not drug related. I knew that I should have done non-pharmacotherapy first, but then we began with hypertension, proteinuria, so I thought I'll cover that ground. This is a strategy, protein restriction, that I would like to talk about in context of chronic kidney disease progression. The Brenner's hypothesis, based on the glomerular hyperfiltration injury concept, it was perceived that probably reducing protein content of the diet would be beneficial, and certainly low protein diet has been shown to be a beneficial strategy in adulthood onset chronic kidney disease. And there is enough data from adult literature that indicates through meta-analyses that there is benefit in using a low protein diet in adults with chronic kidney disease. And guidelines indicate that certain thresholds of intake should be adhered to achieve a low protein diet, and these are the advised intakes by the various guidelines bodies. Now, very low protein diets have also come in vogue, which talk about as low as 0.3 gram per kg per day, which may or may not be useful, and there is some data to suggest that probably they are better than low protein diet, but this continues to be examined. What is most important to remember is that in children with chronic kidney disease, so far we don't have data to indicate that low protein diet is beneficial, and therefore we should be cautious advising children to reduce protein intake, because protein is linked to calories in all diet plans, as well as whenever you are going to restrict protein, you're probably going to restrict calories and limit their growth. So there has been no significant difference from protein restriction, and certainly weight and height would get adversely impacted if we were to advise low protein diet. So this is not recommended for childhood. What about salt restriction? Sure, certainly it improves blood pressure control, it reduces albuminuria, and therefore lower sodiums in the urine are associated with better outcomes in adult CKD, and guidelines would recommend lowering salt intake unless contraindicated. Ultra-processed foods, which are a high source of salt as well, are also shown to be associated with the risk of incident CKD, and therefore one should be cautious around this dietary aspect is important to adhere to, that avoid intake of ultra-processed foods. One therapy that I just want to show one slide on. Do we have time, or do I just go to the conclusion? Dr. Amrish, I'll await your advice on this.
You can finish, then we'll go
All
to the
right.
question.
Okay. So vitamin D analogs were kind of the vogue in the 2010s or so, but we don't see any more data coming in on this regard. But certainly studies had demonstrated that there was a decline in proteinuria and chronic kidney disease with use of the the newer forms of vitamin D, or the analogs of vitamin D. And this was meta-analysis evidence that seemed to indicate that use of vitamin D or its analogs was beneficial in patients. And particularly, there is enough information now, even in pediatric literature, that vitamin D deficiency is very prevalent, and it is associated with proteinuria and progression. And correcting vitamin D deficiency might be beneficial in improving outcomes in terms of proteinuria reduction as well as loss of GFR. There is some suggestion from meta-analyses that higher phosphate levels are associated with higher risk of ESKD and death. Now, whether this is just an indicator of the low GFR or not is not very clear from these studies, but overall it seems that belonging to the highest phosphate levels was worse than belonging to a lower phosphate level for the same GFR categories. So the risks of kidney failure and mortality seem to be increased in patients with higher phosphates, and they probably work through somehow synergistically with ACE inhibitors. So overall, the recommendations in this regard are that you, obviously the vitamin D, you have a guideline for vitamin D now by Dr. Schroff's group, which the Pediatric Renal Nutrition Task Force, which talks about correcting vitamin D deficiency first, followed by use of vitamin D analogs in specific situations. And certainly supplementation with calcitriol is to be given in all categories of GFR, and titrate according to the biochemical panels. What about dyslipidemia? Dyslipidemia seems to parallel renal dysfunction, and there is some data that suggests that hypercholesterolemia and renal disease progression are linked, but this data is not clean enough to recommend that dyslipidemia as a targeting as a strategy. But some data is there to suggest that using statins for dyslipidemia control might delay disease progression. Hyperuricemia is another thing that has been linked to disease progression in chronic kidney disease. Again, hyperuricemia might be linked to various inflammatory pathways, and use of xanthine oxidase inhibitors has been associated with some decline in renal progression. And this would be another target to consider examining in childhood CKD studies. So in adult studies, there is some uncertain evidence to indicate that using urate-lowering therapies might prevent chronic kidney disease progression, but this is not a very clear evidence. There is some evidence to suggest that erythropoietin supplementation, sort of use of the therapies such as ribopoietin or erythropoietin, recombinant erythropoietin, might be helpful in causing renal protection. We are aware of studies in AKI as well as in CKD, wherein it has been shown to reduce oxidative stress-related injury, but this is just observational data. Anemia correction is obviously an endpoint that is part of management, but it does not seem to retard disease progression, at least based on meta-analysis data. Folic acid, again, was another thing that was looked at, whether folic acid supplementation helps. No clear evidence, but there is some data from cohort studies that suggests. Likewise, for metabolic acidosis, that has been linked to chronic kidney disease progression, and correction of acidosis has been linked to reduced cardiovascular disease as well as kidney outcomes. Acute kidney injury, now this is something actually that is more relevant and practical. Preventing happening of acute kidney injury is very important, because bouts of acute kidney injury would reduce GFR each time an acute kidney injury happens. There is a fall in GFR, and preventing episodes of dehydration, other events would be important to prevent rapid progression. So things like use of radio contrast, drugs that are nephrotoxic, obstruction of the urinary tract by, say, stones, etc., and chiefly hypovolemia would be important to address to prevent acute kidney injury events. Very rarely in pediatric CKD, we have occasion to use specific therapies. And some of these are important ways in which progression of these specific kidney diseases can be prevented. I would want to just highlight the story of cysteamine, which has been clearly shown to retard disease progression in cystinosis. Lumasiran and Endorsed that are beginning to be examined, that have been examined in pediatric studies now through the various studies, and have retarded progression of primary hyperoxaluria. Tolvaptan in adult onset ADPKD, which retards progression in the rapid GFR declining group, and then certain other things such as CoQ pathway supplementation in patients with FSGS. In Alport, we still need to have good answers. So just obviously, IgA nephropathy is the most common adult kidney disease. We know that various studies are examining immunosuppression to reduce proteinuria, and we know there's a role for steroids as well as newer therapies such as budesonide, etc., and now the calcineurin inhibitors. ADPKD, obviously, certainly, there are a group of patients who are targets of tolvaptan therapy to retard CKD progression, and the risk determination of these categories varies by the total kidney volume, the rate of change of total kidney volume, family history, and various other risk factors that are used to assess who are candidates for therapy with tolvaptan. For pediatrics, basically the advice is to look at blood pressure and proteinuria and target adequate blood pressure control. There are some studies beginning to examine use of tolvaptan even in children who are rapid progressors or with rapid rise of kidney volume. So overall, I'll stop here and I'll be happy to take questions. This is just my summary slide that our chief targets and control required would be around hypertension and proteinuria, with inhibition of RAS inhibitors being the first line strategy, but then other strategies are beginning to be examined and require further examination in pediatric patients. Thank you.
Thank you, Aditi, for that very interesting presentation. I have one question to you. You highlighted about vitamin D therapy. I'm just reading American Journal of Kidney Disease, Volume 82, Issue 5, November 2023. It is a review. It reads as a result, we agree with the authors that the treatment effects of vitamin D on clinical outcomes among people with CKD are best described as uncertain. Given the negative results of most trials in the general population, it seems unlikely that vitamin D supplements have a broad range of health benefits in CKD. We are not sure. So what is your comment on this? This is the American Journal of Kidney Disease, number 23. So after reading this, I have stopped looking at vitamin D and giving vitamin D therapy to patients.
Actually, in pediatric kidney diseases, I mean, we would definitely look out for vitamin D deficiency and try to correct it, because this is also a period of growth, and achieving adequate vitamin D levels also helps prevent mineral bone disease associated with vitamin D deficiency in this age bracket. So one would still continue to look at vitamin D levels and correct it. There is data which has been put together in Dr. Schroff's guidelines in 2017, if you were to look at those, that support the use of vitamin D to correct, I mean, calcidol, correct vitamin D deficiency, and or work around the phosphate levels to improve phosphate control, etc. But I think I would still stay with the pediatric renal nutrition task force recommendations by Dr. Schroff in this regard, for looking out for deficiency and correcting it where required. So it may not benefit with the GFR decline. I agree. I mean, this is more in interest of the bone health, sir.
Thank you. Any other question in the chat box? You went in detail about all aspects of chronic kidney disease, but you were highlighting on hypertension prevention and proteinuria prevention. I'm so happy that people are now aware of what should be the drug which should be used in hypertension control, and also when to stop ACE inhibitor or ARB, and also the new drugs, endothelin receptor antagonist and other molecules which are available. And thank you. I have no more questions. Amrish, is there anything in the chat box?
There are a few questions, and I know it was a very comprehensive talk and you covered everything. Yes. It was great. I mean, we learned a lot, and especially the newer drugs, I think every aspect was touched. We can quickly go over the questions, see if anything was missed. This is a common question, I think, which is asked, if a child has normal urine protein to creatinine, do we still need to screen with albuminuria?
I mean, we still need good studies to indicate whether PCR and ACR correlate very well in the pediatric age bracket. I think not. I think from a small examination that we have recently concluded that ACR and PCR run quite well together in pediatric CKD. I think if someone has a normal PCR, I don't think I would go for screening for ACR in that condition.
Yeah.
The reverse might happen, sometimes you don't have albuminuria, and you might have proteinuria because of the tubular interstitial compartment being involved.
No, sounds great. Now, do you recommend combination of ACE and ARB in order to control
No.
proteinuria in CKD children?
I think we addressed that with the meta-analysis results of the network meta-analysis indicating the higher risk of hyperkalemia and decline in GFR tells us not to use the combination to achieve better control. We would not be using.
Yep, that sounds great. This is next question is role of statins in proteinuria. When do we start this medication? You did cover, the role of statins, not to reduce the proteinuria, but statins in general for CKD.
Yeah.
Yep, so we can skip that. Next is please explain whether ACE inhibitors are better than ARBs only in diabetic nephropathy. I think Dr. Georgie can answer that, maybe.
Well, we use, in India, the use of ACE inhibitor is much less compared to ARB use. Because we are inherently people who are coughing. And I used to use ACE inhibitor many, many years ago. And then I was constantly coughing, my personal experience. Then I switched over to ARB. And I think that ARB has produced much relief from cough. So it is an inherent obsession that ARB are better than ACE inhibitor, although ACE inhibitors are cheaper. And patients who are on ACE inhibitors who are doing well, I don't switch over them to ARB. That's my answer to the question, Professor Amrish.
Dr.
Thank you,
Amrish,
sir.
we would use ACE inhibitors, and when there is cough, then we switch to ARBs, and that occasion thankfully has been rare. So I know that children cough more also than adults, but we rarely encounter need to switch over to ARBs. And for us, our favored therapies would be ramipril and enalapril compared to ARBs.
Yeah. No, thank you. I think that was great discussion. And again, a very common question which comes up with trainees, and especially difference between pediatric and adult, how it is. Then the next question is, please advise how do you treat a CKD stage 3 child who has significant proteinuria due to scarring despite maximum dosage of ACE? It's a 15-year-old child. And do you recommend SGLT2 here?
Not yet. We need more data in pediatric patients. I know that many centers or individuals are using SGLT2 inhibitors already, but based on a small study done at our center, and we continue to examine this in an RCT currently, a placebo-controlled RCT is ongoing at our center. Dr. Jitendra and Pankaj are leading that RCT, in which we are looking at dapagliflozin versus placebo. But when we did a prospective single-limb study, which is as a manuscript draft right now, we did not find reduction in proteinuria as an add-on, and we found an acute decline in GFR. So one is wary, and adults are more robust than children. Children are more prone to hypovolemia. We have to be careful, particularly if your patient is reflux nephropathy, may not have so much of a concern, but certainly in steroid-resistant nephrotic syndrome, albumin levels are low, risk of hypovolemia is high. One would be really wary of using SGLT2 inhibitors. We need more studies. First, we need studies, then we should advise.
Sounds great. And the next question is more for CKD MBD, and I'm going to skip that one, when to use active vitamin D calcitriol, so that our discussion stays with the progression part. And the last question is use of finerenone, which is the mineralocorticoid receptor antagonist in pediatric CKD. You did cover that. Maybe you can answer that a little bit more.
So there's no data in pediatrics so far, not a single study, no prospective, retrospective, nothing. And it required the Fiona study. When it's done to completion, it should be able to give us the answer. The Fiona study is looking at pediatric CKD and the rate of GFR decline as well as proteinuria decline with finerenone add-on to ACE inhibitors or ARBs. And it's continuing to recruit patients, including beginning in India now, including at our site. So let's see what comes of that.
No, perfect. No, this was great, Aditi. This was so educational. And Dr. Georgie, this was so much, educational for us, for you to be here and give your expert opinion. We all learned a lot. I can see in the chat, that this has been an excellent presentation, outstanding presentation. This has been a great session. Thank you, Dr. Georgie. Thank you, Dr. Aditi, for all your time.
Yes, thank you, my distinguished colleagues from abroad and India, for this very lucid as well as, detailed explanation by Frank as well as by Aditi. And we look forward to more such sessions in future. And I really congratulate Kalaivani single-handedly, the ladies' power, the women's power, single-handedly doing all these things. Congratulations to her. Thank you, Amrish, and for taking this time off from your work to educate us. Thank you very much.
Thank you, Dr.
Thank you so
Jyoti,
much,
and
sir.
thank you, Dr. Amrish
Thank you,
Kalaivani.
Dr.
Thank you.
Aditi.
Thank
If
you.
you want, we can log off. We'll have the polling session next. You
Yeah.
don't have to stay for that. I know we're a little bit over time today.
Thank
So
you.
please, go ahead with your regular day. So now we are going to start the polling session. As we all know, that please enter proper email ID and contact number during the process of registration for the ease of future communication. We have a total of 6 polling sessions, which happen every Wednesday and Saturday. Each polling session will have 10 questions, and it's mandatory to answer all the questions to proceed with the submission. Total duration will be 5 minutes for the polling session. We'll have 4 star questions in each session, and star questions are taken into consideration in case of tie. Cumulative score of all 6 polling sessions will be taken as the final winners are selected. We have 3 cash prizes, and only trainees are allowed to participate in the polling session. Request the participants to log in on time using a bigger screen for easier view of the questions, and for better view, you can use iPad and use the landscape mode. Once you log into to the webinar, you can avail the polling sessions. Can we please go ahead with the polling sessions? Can you please go ahead with the questions? I think the time starts now. We'll give 1 more minute. I think that should be it. We can close down the polling session. Again, thank you everybody for joining. Thank you, Aditi, again for being part of this. We really appreciate all your help and all your support. And thank you, Dr. Georgie, for joining. Dr. Kalavani, thank you again for being there all the time. And we will see everybody on Saturday. Thank you. Bye-bye.
Bye, Amrish.
Thank you. Bye-bye.
Bye.